Hi, everyone. I am Dr. Annalise Cothran, Executive Director of the American Institute of Dental Public Health. Welcome to Day 2 of Transforming Veteran Oral Health, the AIDPH colloquium planned jointly with CareQuest Institute for Oral Health. For those who may be new to AIDPH, we are a 501c3 nonprofit focused on the science and education of oral health, pursuing our mission through the lens of oral health equity. We began our Veteran Oral Health Initiative near the beginning of 2021, focused on 3 key areas: access, research, and advocacy. As the wife of a Purple Heart veteran and a beneficiary of the military healthcare system, I have a sense of personal obligation to support the broader veteran community, understand their oral health needs, and amplify solutions that advance equitable care for veterans. Near the end of 2021, we co-authored a forward-thinking white paper with CareQuest Institute, defining 8 strategic recommendations for improving access to and quality of oral health care for veterans. These 8 strategic recommendations serve as the framework for this conference, planned jointly with our colleagues at CareQuest. I want to thank our partners at the American Dental Association, Delta Dental Foundation, Aspen Dental, and Patterson Dental for their support of this conference. These partners have not only invested in veteran oral health through this event today, but have initiatives within their own organizations supporting veteran dental care. We are truly honored to feature their work here and encourage attendees to learn more about their commitment to veteran oral health during the coffee break right after this session. Like with yesterday, you'll hear more about our philanthropic partners at Fisher House and Minority Veterans of America. Today, our philanthropic partners at Minority Veterans of America are a nonprofit organization supporting veterans of color, women, LGBTQ, religious and non-religious minorities, and allies. They're building a movement in the veteran community, and AIDPH is proud to join them. We encourage you to visit their lounge during the coffee break and support their mission. Before we review today's agenda, I want to give a special thanks to our team members who planned this event and will be supporting the sessions today. This has been a large undertaking, and we could not have implemented this conference without each team member's contribution. Today's agenda includes this plenary session, followed by a coffee break with our poster presenters, philanthropic partners, and conference sponsors using the lounges and the Hublot platform. When you return from the coffee break, you'll choose between 2 concurrent sessions and then move to our final plenary session of the conference. You'll have AIDPH team members guiding you between breaks, and you'll navigate to sessions using the Hublot platform. Sessions will be in meeting format, and we encourage you to use the chat feature to interact with your fellow attendees throughout the day. For a bit of housekeeping, we're asking you to please keep your video and audio off while speakers are presenting so that we give them our full attention and they are not being distracted by us and we are not distracting others. Continuing education credits are available for these sessions. Attendance is verified by codes given during the sessions. You'll receive the codes, keep up with them, and you will enter them into the conference evaluation after today's sessions end. All sessions will be recorded and made available after the conference via our YouTube channel. And we are also asking attendees to add your personal pronouns to your Zoom name. You can do that by hovering over your video box in Zoom. There will be 3 dots in the top right corner. You simply press those dots and hit rename. Now I'm pleased to introduce my colleague, Dr. Sean Boynes, moderator of the Fostering Care Team Innovation for Veteran Oral Healthcare panel. Dr. Boynes is a dentist anesthesiologist who received his DMD from the University of Pittsburgh and completed a 3-year residency in anesthesiology from the University of Pittsburgh Medical Center. He currently serves as president of Dental Medicine Consulting, where he supports national programs and initiatives focused on the integration and coordination of person-centered care, creating and implementing value-based strategies, and utilizing data-driven insights to empower the patient and individual to own their own oral health. Dr. Boynes lives in Pittsburgh with his partner, Vicki, and sons Smith and Maverick, and enjoys hiking and playing guitar whenever possible. Thank you so much, Dr. Boynes.
Thank you very much, Annalise, and thanks to everyone for welcoming us into your homes, your work environment, your hotel room, or wherever it is that you find yourself today. Hopefully a few people were on a plane just to make it a little bit interesting. So today we are going to discuss one of the hot button issues that are out there, which is workforce. As I think all of us know, our oral health care teams are the backbone to oral health and serve as the largest infrastructure for oral health that we have. Unfortunately, there's been some deterioration through the pandemic of this infrastructure and of this workforce. And in fact, the American Dental Association's Health Policy Institute recently found that almost 87% of dentist and care delivery organizations are either extremely or very finding it extremely or very challenging to be able to recruit and retain dental hygienists and assistants and other members of the workforce. You add this to the fact that we know many dentists are retiring a little bit earlier than expected, and that these tend to affect underserved populations and underserved communities like the veterans community a little bit more strenuously. So there is a need for us to understand and learn from thought leaders across the healthcare system what facilitators and challenges are in place so that we can move forward oral health for all. Thankfully, our panelists are here today to initiate discussion and care team innovation for veterans oral health. And I'll give a brief introduction and we'll get into some of the questions that we have available. I will start out by saying none of our panelists are reporting any conflict of interest. And we'll start with Dr. Scott Trapp, who is a dentist and deputy to the Assistant Undersecretary for Health for the Veterans Health Administration Office of Dentistry. He has served as a chief dental officer at a number of VA and Indian Health Service facilities during his government career. He has also held numerous national leadership roles, including the chairman of the Standards Committee on Dental Informatics at the American Dental Association. Mr. Fred Leventon is the president and CEO of the Dental Lifeline Network since 2011, having previously served as a vice president and chief operations officer from 1976 to 2011. His primary responsibility is setting proper strategic direction for the organization and creating an environment and culture for furthering the organization's efforts to improve the oral health of people with disabilities who are elderly and medically fragile. Dr. Dawn Weaver is a physician and has a lifelong commitment to improving the health of underserved communities and vulnerable populations through community-responsive, culturally competent care delivered by interprofessional teams. He currently serves as Senior Advisor, Clinical Workforce for the National Association of Community Health Centers, or NAC, as we affectionately call it. Prior to this position, Dr. Weaver had a distinguished career as a commissioned officer in the United States Public Health Service, retiring with the rank of the Assistant Surgeon General. Gentlemen, thank you so much for joining us. It's appreciated, and I will provide the first question, which will go to Dr. Trapp, then Dr. Weaver, then Mr. Leventon. Can you all provide us with a brief elevator pitch to describe how your organizations improve the oral health and thus health of veterans? Dr. Trapp?
Thank you, Dr. Boynes. As the world's largest integrated healthcare delivery organization, the Veterans Health Administration fulfills President Lincoln's promise to care for him who shall have borne the battle and for his widow and his orphans by serving and honoring the men and women who are America's veterans. Former service members are eligible to enroll for VA healthcare benefits if they served on active duty after October of 1981 and served 24 continuous months, or were discharged with a disability that was caused or made worse by active duty service, or they may have been discharged for a hardship or an early out or served before September 7th, 1980. VA dentistry honors America's veterans by contributing to their whole health through the provision of exceptional oral health care. We do this through the statutory authority granted to us by Congress in USC 1710 and 1712. These two statutes allow the VA to provide comprehensive, recurring dental care to former POWs, veterans with a compensatable dental disability rating, or service-connected dental trauma rating, 100% service-connected disability rating, or unemployability rating. Limited or focused dental care is provided to all other veterans when they have a dental condition that could directly impact the management of a medical condition, such as a heart valve replacement or organ transplant. Limited or focused dental care is also provided to veterans enrolled in special authority programs, such as recently discharged veterans, inpatients, vocational rehabilitation, homelessness, nursing homes, and domiciliary programs. There are 8.7 million living veterans enrolled in VA healthcare. Of those, 5.2 million have a rated compensatable service-connected disability, and 3.6 million have a non-compensatable service-connected rating. The number of veterans eligible for comprehensive dental care is growing dramatically. From 2016, we have seen the number increase from 918,000 to just over 1.4 million, a 50.2% increase for a dental care system that has grown by less than 10% during that same period. Our nearly 3,600 dental staff members, composed of nearly 1,100 dentists, 450 dental hygienists, and 1,600 dental assistants, manage the care of nearly 550,000 veterans that received 5 million procedures through 1.9 million visits during fiscal year 21, despite the challenges of the pandemic. The value of this care using average and usual customary fees at the 50th percentile is nearly $1.2 billion. The quality of this work is reflected in both our patient satisfaction scores and dental quality measures. Our patient satisfaction survey scores routinely exceed that of the private sector for the majority of the items surveyed, and our dental quality indicators meet or exceed national benchmarks. Not only do we meet this operational portion of our mission, we also meet the research and educational pillars, where we currently provide the training environment for 350 dental residents. Thank you, Sean.
Dr. Weaver, I'll turn it to you.
Thanks, Sean, and good morning, afternoon, everyone. I guess it's not afternoon for anybody. It's still morning for everyone. Health centers were founded on the principles of community-oriented primary care, and NAC has the privilege of serving as the voice for health centers. When I say health centers, I'm referring to all components of the 1996 Consolidated Health Center Act: community health centers, migrant health centers, health care for the homeless programs, and primary care in public housing. Those principles of community-oriented primary care are community-driven, and health centers are community-driven by patient majority governing boards, providing a comprehensive set of services based on the community's needs and open to everyone without regard for their ability to pay. Certainly, everyone includes veterans and their families. We have national efforts to focus on veterans' health through employment opportunities for returning warriors and their spouses, assuring veterans' voices are heard by health center boards, learning from our health center veterans interest group, and establishing and nourishing existing partnerships, such as those with the VA, CareQuest Institute for Oral Health, National Network for Oral Health Access, and the Oral Health Progress and Equity Network. What do the numbers tell us? From 2010 to 2020, there's been an 86% growth in health center dental staff. And that same uniform data system from 2020, there's a caveat here with the COVID-19 pandemic, as Scott mentioned, 5.2 million people received dental care in health centers. And while we cannot cross-reference those 5.2 million who are veterans, we do know that 867,000 veterans were provided care in health centers. And we believe that count is low as we're increasingly gaining knowledge on how to ask for an individual's veteran status. But really, this story is about more than numbers. Let me share two brief stories with you. Sioux Falls Health Center in New Jersey, as many of you heard yesterday, NAC has partnered with the VA Center for Care and Payment Innovation to help pilot VA Vet Smile, connecting veterans with dentists in their communities. I can't tell you how excited we are to look forward to hearing from Eva Turbiner and Sam Wackham from Sioux Falls Health Center to learn about the lessons that they've learned in this exciting pilot and how this model can be spread to health centers across the country. Another example is Family Health Centers of Marshfield in Wisconsin. Greg Nitsch, their CEO, reports that when he and his team surveyed county veteran service officers across Wisconsin, what they found out was access to affordable dental care for low-income veterans was one of the greatest health-related challenges they faced. Family Health Centers of Marshfield, like all health centers, offers minimal or low-cost services to individuals living at or below 200% of the federal poverty level through a sliding fee scale. Despite that, some veterans continue to experience financial challenges related to out-of-pocket expenses. So Marshfield Family Health Center applied for state funding to meet that need and were able to expand what they were able to provide for veterans. Greg is also quick to point out that they have a target of assisting recent high school graduates who wish to pursue a military career to assure that oral health does not prohibit them from realizing their dream. These are just a couple examples of the ways health centers are meeting the needs of veterans in their communities. Sean, back to you.
Thanks, Dawn. Fred, I'm going to pass over to you.
Good morning, everybody. I'm Fred Levitin. I am I'm retiring soon, president and CEO of Dental Lifeline Network. We're a national humanitarian organization, charity that increases access solely for people with disabilities, who are elderly or medically fragile. And usually most of these folks don't have the money to pay for any kind of services. Through our donated dental services and our Will You See One Vet programs, nearly 15,000 volunteer dentists and 3,400 laboratories across the country will donate over $22 million worth of services in this year. 12,000 people with disabilities or who are elderly or medically fragile will benefit from comprehensive dental treatment. That's one of the limiting factors of the services that we provide, is that we only provide comprehensive treatment rather than basic kind of services. So that limits the people that we help. But in another way, it makes the care much more meaningful for those that are able to receive services. I'd like to talk about, just for a minute before I get started, a case I want to bring forward to you, and we have lots of cases. We don't have a whole lot of dog and pony show in terms of the care that we provide, because most of it is done in the offices of dentists, and it doesn't make a whole lot of compelling interest to kind of show, here's a dentist treating a patient in a chair. You've all seen that. But let me tell you about some of the people that we do help. I'm going to give you one example of a veteran, 59 years old, from Missouri. His name is Leonard. He suffers from several serious health challenges, including congestive heart failure, COPD, diabetes, degenerative joint diseases, and glaucoma, among others. Unfortunately, his dental health was another challenge. Several teeth were missing and others were decayed and broken. An existing crown had broken off, and Leonard was in so much pain that he could hardly eat. Unfortunately, Leonard was unable to afford the treatment needed to address his deteriorating dental health, and he did not qualify for dental care from the VA. No longer able to work due to his health, he survives on Social Security disability and VA benefits and struggles to make ends meet. He was barely getting by, and dental treatment seemed far beyond his reach. Thankfully, 3 local generous DDS volunteers, DDS is our acronym for Donated Dental Services, came to Leonard's aid. An oral surgeon extracted 5 teeth, a general dentist restored 4 teeth, and with the help of a volunteer lab, donated 2 crowns and upper and lower partials. Thanks to these caring volunteers, Leonard received more than $9,400 in donated treatment that restored his health, relieved his pain, and gave him a new smile. And we have lots and lots and lots of those kinds of stories every day that reflect the kinds of services that our volunteers provide to both people with special needs, including many veterans. So I mentioned earlier that we're going to serve about 12,000 people in this year. About 10% of them will be veterans, and who, like the other patients that we serve, can't afford care nor get the comprehensive treatment they need from any other sources. And sometimes this case is even, although often life-changing, even life-saving, when people need cancer treatment, when they need any kinds of organ transplant and so forth, they can't get any of those services, those essential medical services, unless their dental needs are met. Leonard, like many veterans, receives medical care from the VA, but because of congressionally mandated limits, he could not get dental treatment from the VA. And Dr. Trapp had talked a little bit about the eligibility required to get dental treatment, but there's lots of veterans out there that are unable to access those kinds of services. Thankfully, many dentists are very willing to pitch in and help. The American Dental Association and many of its state dental association constituents encourage their members to help. And we receive significant financial support to be able to link these patients with volunteer dentists from Delta Dentals and the Guardian Life Insurance Company. So thank you.
So thanks, Fred. And while we have you front and center on the camera, I'll throw the first individual question your way. So within the private sector and programs like Dental Lifeline Network, they've become essential in getting needed dental care to our veterans. Can you tell us about the needs that veterans you serve have, how severe or not the oral disease is, and if treatment plan completion or the ability to get the care completed has been affected by the COVID-19 pandemic?
Okay, it's hard for me to give a great perspective on the severity and the extent of the problems that veterans have. We just see what we see when we reach people and they get to us. We'll try to help them, but we know that the problems are extremely pervasive, affects far more people than I can count on my hands, which is about as far as I can go. And we just know that there's just lots and lots of unmet need. And one of the limiting things about our services, for what I think is a very compelling reason, is that we only will accept people with seriously neglected problems. We feel that if they need basic kinds of services, that's a lot easier for them to afford. That's a lot easier for community clinics to help with, but it's the comprehensive kinds of services that are difficult for other kinds of organizations to help with. So that's why we focus strictly on getting comprehensive treatment, and the average value of a completed case is anywhere between $4,000 and $5,000 for us. So typically involve fabrications and a lot of extensive care. In terms of COVID, we, like everybody else, have not been able to escape the wrath of this pandemic. Earlier, you mentioned that lots of dentists are retiring. A lot of our volunteers are retiring. Far higher percentage than we've seen in the past, and a far higher percentage than we're able to replace easily, taking a lot more work. So it gives us a smaller volunteer base in which to help people. Similarly, because of the other problems that were mentioned with workforce and dental offices, the dentists are taking a lot longer to complete cases. Most of our volunteers will help one patient at a time, which typically means one patient a year, maybe sometimes two. Prior to COVID, probably 6 months plus was the average time it would take to complete a case from start to beginning. Now we're seeing well over 12 months. So what happens is those dentists who would volunteer, they're tied up because they only treat one patient at a time for us. They're tied up and we're helping fewer people than we normally would.
Thank you. For the next question, I'm going to turn it over to Dr. Trapp. Currently, within the dental profession overall, we find that there is a desire and a need to enhance preventive culture. Can you discuss if there's a need to advance a more prevention or preventive first strategy for the Veterans Administration and how the VA workforce may need to be enhanced to do so?
Great. Thank you, Sean. The preventive model of dental care is critical to the long-term success of VA dentistry. The Office of Dentistry takes every opportunity we can to emphasize this preventive versus surgical or episodic model of dental care. As evidenced by several peer-reviewed publications, we've been leaders in research related to fluoride use and caries reduction. From a staffing perspective, we continue to highlight the use of dental hygienists. We're in the early stages of implementing staffing model recommendations. We would have one dental hygienist per dentist to ensure both dental hygienists and dental assistants provide care at their highest level of licensure or registration from their particular state. As previously noted, we have nearly 1,100 dentists and only 450 dental hygienists, so we have a long way to go to meet our recommendations. Our challenges are mostly related to space availability and an HR system that can be challenging to navigate. Advancing the use of dental hygienists is critical to promoting a preventive culture within our veteran population and our staff. We fully recognize the dental hygienists possess the training and skills to fulfill this goal. Another way that the VA leverages workforce is through our without compensation employment status. Several of our dentists practice in the VA on a part-time basis without compensation. These dentists are from both the private and academic institutions. This is one of the ways that we can provide highly specialized dental care to veterans. If anyone is interested in contributing to veteran care, this option might be available near you at a VA hospital by contacting the local dental service chief to see if such an opportunity might exist. And I'd be happy to elaborate more, Sean, if you'd like, if you have any further questions on this.
So just a quick follow-up to that is, as you're thinking about workforce changes and the maneuvering that is most likely going to come in the future, how are you thinking about interprofessional care teams and how you're tying in, say, dental hygienists into some of those structures in order to make access a little bit more widespread?
So as far as access goes, we currently collaborate in a variety of ways within our VA system. So we're a fully integrated system. We're what we've been talking about during this colloquium over the last day. The VA has been doing this for decades. We're very proud of that, and we'll continue to push those efforts forward. The other area, in 2017, when Congress passed the Mission Act, it really expanded access to care for veterans, where now we're partnering much closer with our community care partners. And in those partners, we have to develop that relationship to understand the best ways of extending those limited government resources to provide effective dental care delivery. We have to understand that dental care is not just about a profit motivation, but also about developing that prevention model so that we can ensure the best care for veterans in their long-term success based upon their individual needs. Some veterans may need higher levels of care, some may not need such high levels of care. So that's one of the challenges that we face in that partnership with our community providers.
Well, thank you for that, Dr. Trapp. And I don't think you could have given me a better transition to go over to the illustrious Dr. Dawn Weaver. So, Dr. Weaver, Dr. Trapp brought up the Mission Act from 2018, where the VA expanded access to care for veterans through the Community Care Network, which comprises 6 regional networks that serve as a contract vehicle for the VA to finance care for vets with community providers. Can you describe how FQHC dental programs are adjusting care teams to provide community care from a diversified workforce perspective?
Thanks, John. Great question. I'd like to reframe it, if I may. And those of you that know me well know I will talk about oral health programs, of which dental care is an essential component. But we really look at the opportunity to sort of retool, reframe our care teams in the concept of oral health care team being the whole team. And if you look at even the numbers, when you look at all the clinical care team members that we could possibly include at health centers, it's over 250,000. If you looked at our dental team, it's a little over 17,000. So if you look at the two of those, you'd say you need to involve more people in this activity. And I think that's what we're doing and moving toward. It's consistent with a basic tenet of the patient-centered medical home. I like to call them people-centered health homes. everyone working at the top of their licensure, training, and certification. And we've sort of used as our framework HRSA's integration of oral health and primary care practice, because it gave us that starter set of clinical competencies of risk assessment, oral health evaluation, prevention interventions, communication and education, and certainly last but not least, interprofessional collaborative practice. And we've used that as a guide to provide answers for who on the care team can be trained to address each or any of these issues, freeing up time for that dental care team to do what they and only they can do. So from community health workers and promotores to medical assistants to physicians, nurse practitioners, certified nurse midwives, we're really looking at how we can mobilize that team in the area of oral health. And we're also looking at expanding the dental care team with dental therapists. The latest data is we have 30 dental therapists working at health centers across the country, and it gives us a baseline for work that we hope to use and expand. One of the side effects of the pandemic, I'll call it a side effect, was the necessity to expand in teledentistry. And we're committed to helping assure that this remains a component of oral health care in health centers. And sort of last but not least, we're continuing to encourage and be participants in a health record interoperability. We know that if we're going to expand this team, one of the things that's essential for us to have is a true electronic health record. I guess, Scott, you all have that advantage in the VA, but we certainly don't outside your system. And I'm sorry, Scott, Sean, the one other thing I want to mention is we sort of have a North Star for our workforce. And that is, we want a workforce that reflects the populations we're privileged to serve. And we know where the perfect candidates are. They're in our communities. So we're always looking for ways and programs that allow members of our health center communities to get on a pathway to become a member of the care team. And that certainly includes veterans and their families.
Thanks, Don. I appreciate that. And the reframing, I think that was fantastic. To move over back to Scott, since you did mention him on interoperability, and Dr. Trapp, you mentioned this earlier, the veterans really come from all walks of life and represent what we used to call the melting pot of the United States. So ultimately, there's a continuum of care that's needed that reflect things like social determinants, geography, and well-being. And while the VA sees those most in need and often most medically complex, would a more universal benefit design or a dental benefit plan for all veterans be beneficial or advantageous?
Great. Thanks, Sean. Thank you, Don. In the VA, we're fortunate to have sophisticated information management tools. This information management system and tools help us to ensure that we provide the right care at the right time and at the right place. During the last 2 decades, the VA has served as a model for developing and leveraging an information system architecture that ensures that we can provide dental care that is safe, efficient, effective, accessible, patient-centered, and equitable. This is accomplished by using our electronic dental record as the foundation. The VA electronic dental record is much more than just a charting system with an odontogram for recording procedures for billing purposes. Our electronic dental record system records dental examination and treatment components in a structured data format that can be used for research and improvement of our overall oral healthcare delivery system. This allows us to calibrate our dental care team for consistency with the VA goal of being a high reliability organization. Since the system is also fully integrated into the overall health record system, we can address patients holistically by utilizing past and current medical problems and pharmacology as examples. This information is then utilized in our geospatial information systems to ensure operational capabilities are available where most needed in a cost-effective manner to the taxpayer. We are now leveraging our geospatial information systems to understand geographic disease patterns so that we can effectively target resources and interventions. The VA dental benefit is far-reaching and much broader than traditional dental insurance benefits. When considering a universal dental benefit for veterans, the 2 key factors that must be addressed are the scope of the dental benefit and the appropriate resourcing. Failure to address each of these items will result in a system of care for veterans that will not be prevention-based, but rather episodic in nature.
Thank you, Dr. Trapp. We'll move over to Fred. As we talk about one of the challenges with wonderful programs like DLN is sometimes there are more providers willing to help, but difficulty in getting the word out that the program exists in different communities. Can you provide a wish list of organizations or agencies you feel would help in getting veterans more connected to programs like yours?
Sure. One of our biggest frustrations is that in a number of areas, we've had a number of dentists that have volunteered to help veterans, and we have a really difficult time in terms of finding the people that are out there. We know they're out there. We're just not messaging in the best way to reach all of them. So it's a huge, huge frustration for us because we know we could provide more help to more people, yet we're limited by our outreach abilities to certain people. So first of all, I think there are many people in this that are viewing this presentation that might be in a position to help in their communities, and we would love to talk with them. And if possible, we would love to be able to help some of the folks that can't get care in any other way. There's a couple of communities I'd just like to point out, although it's certainly not reflective of all of them, where we have a real surplus, I guess, of volunteer dentists willing and able to help. That would be in the states of Connecticut, Delaware, Wisconsin, and Massachusetts, as well as in New York City. So if any of you folks out there can help in that way, that would be great. In response to your question, direct response to your questions, we would love to be able to collaborate more with federally qualified health centers, with VA dental clinics, social workers, anyone in communities that are in a position to know about veterans that could benefit from comprehensive dental care that we can offer.
Thanks, Fred. And with that, when talking about the community and where people are at, I'll turn to Dawn. As federally qualified health centers see individuals regardless of their ability to pay, it becomes vital to improve the health of the community that goes beyond just enhancing access to care. Can you provide some examples of how the FQHC workforce beyond those clinicians, those clinical providers, work to help community efforts that improve quality of life in those communities and the people that are living there, many of which are veterans?
Sure, Sean. Great question. And as mentioned in response to your previous question, we have a broad definition of providers. Who has the needed competencies to improve individuals' health, and probably the sad news that we're reminded of on a daily basis is, at best, about 20% of health is influenced by what we do in exam rooms and operatories. So it's really reaching out into the community. And to obtain that optimal health for all, we address the social drivers of health. Sometimes we have referred to that as enabling services. I think we now talk about a variety of services that need to be addressed to meet the needs of a diverse population, and also recognizing that it's not done just by health centers. It's really about partnerships in the community. So it's whether that's translation services and who else in the community can assist with that, whether that's transportation, whether that's enrollment assistance for Medicaid and insurance. Examples that I heard just recently of health centers sponsoring community gardens, making sure that people have access to the nutrition and foods that are healthy for them. Also addressing sanitation and environmental issues. And partners include people such as the YMCA and the cooperative extension. And I think in all of those areas, it's a way of improving the health of the community, and certainly members of that community are the veterans and their families.
So thanks, Dr. Weaver. I do, in keeping an eye on the time, I'd like to be able to provide a few questions from the audience that have come in. One, I think this is addressed to you, Scott. It says, how is the Mission Act being communicated to dental chiefs throughout the nation to be able to refer to other organizations for veterans not eligible for VA dental care.
There we go. Sorry about that. I think we talked a little bit about that. Dr. Ghosh mentioned the statutory authority that allows us to expend government resources for non-eligible. So the statutory authority kind of limits those within the Office of Dentistry of managing care for non-eligible veterans. And I think I'll refer back to the way Dr. Ghosh put it yesterday. And I think the Vet Smile program is helping to fulfill some of that gap. As far as how we communicate the implementation of the Mission Act to our VA dental service chiefs, we have very rich training programs for that. And we've seen a real shift within the VA where the workload has increased dramatically as the Mission Act is actually fulfilling what Congress had intended by expanding access to care for veterans.
Thanks, Dr. Trapp. Another question came in addressed to you, Dr. Weaver. You mentioned VA's community care program, which has aimed at expanding access for veterans. We've heard that delayed reimbursement is preventing some dentists from participating in the community care program. Has that been a problem for your FQHC members in your experience?
Also a great question. As people know, in my experience, maybe very limited because I'm not the expert on the payment side. What I will tell you is that, whether payments are delayed or not, the majority of health centers that I've interacted with participate in all programs that are improving the health of individuals in their communities. So if that's a delay in the community care program, I know people will be persistent about it. And I think what they do is work not only individually, but in their given state or area or nationally with their state primary care associations or with NAC to say, this is an issue and may prohibit us from moving forward. But I've not heard anyone saying that, they wouldn't expand services because of a delay in payment. I think they get out and do what needs to be done. And the administrative side works as hard as they can to get the payment in a reasonable time. So I've not heard that as an issue, but I also will caveat that with I'm not the finance expert at NAC. I'd be happy to check into that if indeed, or if others know, you can jump in.
It was my pause waiting to see if others would jump in. I think new programs are always going to have these challenges and they have to find where those facilitators are at. Appreciate Dr. Weaver as you guys continue moving this pilot forward, maybe making sure we regularly understand where those things are at as you guys talk about it will be extremely helpful. I will move to the next question and throw it out to the panel. I think it's an interesting one, and given that it's from Dr. Steve Geierman, I think who is notorious for throwing these poignant questions out. It seems like we are still dancing around the question of securing oral health care for all veterans, not just the ones who have a service-connected oral health disability, which is a dental issue. It does bring up the point of how do we get to an effective universal benefit for veterans? And where are the complicating factors that make it difficult to have wide-ranging discussions around trying to get to those solutions when the challenges tend to come up front? And Fred, I wouldn't mind bringing you into this to see, having a universal benefit, I assume, would make life a little bit easier for your program across the board. So maybe start there, and then Dr. Trapp, maybe you can come in on the back end of that as well. So Fred, I'll turn to you first.
So I'm going to probably give you a slightly jaded response. When you're talking about a universal system, you're talking about government funding, you're going to be probably talking about less than optimal fees for dentists, which means that it's somewhat going to limit the participation. And similarly, if you do it through a public health system, you're going to be limited in terms of the number of providers that would be out there. So even if we did have care theoretically available to everyone, I suspect there would be lots of holes and there would be a lot of people falling through those cracks that would have a tough time accessing care. But it would be a great start And it would be a huge benefit to a lot of people, I imagine, that aren't getting any services right now.
Great. Well, if I could chime in, I think here in the Office of Dentistry, we've worked on this particular problem, and it answered several questions from our congressional colleagues. I think the real challenge is what it always boils down to is the same thing. It's time, resources, and money. And it always boils down to that money part, right? And and also that scope of care, and making sure that we're partnering to provide care that is reasonable. And we don't hear a lot of people talking about that. But I'll give you one example that we live with on a regular basis. And I'll tell you, the dental service chiefs within our system tell us about this every day, about dental treatment plans that come in that lack diagnostic codes, lack clinical documentation, but are requesting care in these treatment plans. I've got one sitting on my desk right now in front of me, $121,000. How can we fund a system of universal care at $121,000 per individual? Obviously, that's the extreme, right? But we look at this in what is that quality of care component? How do we define that dental benefit plan? Does everybody that becomes a dentist get an all-on-4? And we have to answer these very hard questions before we can start getting into that funding piece as well.
So thanks, Dr. Trapp. I will move to a question for the entire panel and allow you guys to come in. I think it was addressed to one of the panelists, but I think it can be applicable to all. If you look at what this colloquia or ones like it are doing, is it's really shining a light on where a need is at, and finding that, like other populations, but maybe more significantly for veterans, that the need for oral health is far exceeding what it's insufficient to meet the current existing needs. Can you each, from your individual organizations, and we'll consider this the last question and go to the next portion of this, can you guys please see what is the role of your organization to meet the needs of veterans and possibly extending or expanding eligibility to more veterans? So, Fred, maybe from your perspective, is what is the private sector role that can help if we're expanding eligibility? Dr. Weaver, how the community and community health centers can step up, if you will, in order to help. And Dr. Trapp, maybe from the VA, what is the role of the VA to help make sure we're pushing, extending, and expanding eligibility? So, Fred, I'll start with you, Dawn, and then end with Dr. Trapp.
So in the context of all veterans, our organization is going to have a very finite impact. First of all, we limit our services to veterans with special needs. So you're factoring out all sorts of people to begin with who could be eligible for services. Secondly, we also only provide comprehensive treatment for people with seriously neglected problems. So again, you're going to factor out a number of other people. On the other hand, so it gives us a very finite group of people to whom we could help. What's encouraging, I think, is we got really serious about helping more veterans a few years ago. And we did a recruitment with the American Dental Association to encourage more of its members to volunteer. And through that campaign a few years ago, we got almost 1,000 dentists that volunteered and said, I'm happy to provide care to one person a year. And we've held back a bit because we've had some problems in places I mentioned earlier, that sometimes we have volunteers, don't have enough patients, and trying to balance that all has limited our outreach to potential volunteers, as is COVID, with being such an uncertain environment. But I think there's a lot of folks out there, at least in our limited world, there's a lot of dentists out there in the country, I think, that would be more than willing to step up. And I think what I'm hearing from some of the other folks, as well as from what I said, is that there's not going to, even if you have a universal system, there's not going to be a universal system. It's going to involve a lot of different players, both public and private, if we want to help a significant number of veterans get access to the care that they need.
Thanks, Fred. Dr. Weaver?
Sean, I think the answer is probably twofold. One is awareness, to make sure that veterans in the communities know about health centers. I say that because, when I was in the federal government, I used to come back from trips and somebody say they didn't know about that health center. And I'd say, I thought everybody knew about that. So I think getting the word out. I think the second thing is what we talked about with recruitment strategies. I'd be less than upfront and honest to tell you that staffing is an issue at dental clinics and health centers. And I don't run across too many that say, oh, we have 50% vacancy rates and are trying to find patients to fill them. So I think a combination of looking at expanding the team and the facility capacity to care for individuals, looking to do a better job of integrating it. And I think specifically for veterans, to make sure that the individuals and organizations supporting veterans know about health centers, and also know that we'll do the best we can to make sure that we can expand access and include veterans in that expansion.
Dr. Trapp, we'll turn to you to answer the question, and this will be the last portion of this panel.
Great, thank you. And it's such an honor to be here with so many esteemed colleagues that are on this panel. So thank you once again for the invitation. From the VA perspective, one thing I think we need to get out there on the table is the VA is an operational agency within the federal government. We're not an advocacy agency, so we do not lobby Congress, and actually lobbying on a government official is rather frowned upon. So the need to expand, or the goals that we're trying to reach, those really are driven through Congress. We need to follow our governmental system that we have in place. I know a lot of people reach to the VA and reach to people like myself and my colleagues to say, what is the VA doing? Well, we fulfill the mission that we are given the authority to fulfill. But I think we need to go back and talk a little bit about that workforce issue and what the impact of that is. Right now, our limiting factor within the VA is not getting a dentist hired. We're a highly desirable place to work. We find that in our own employee surveys. The ancillary staff, meaning the dental assistants and the dental hygienists, we need to do a better job there. But dentists, we don't have too much of a problem. The challenge will be is if and right now our resource limitations are on the number of dental treatment rooms, where we're kind of landlocked and trying to build out and get more space within those limited resources. That's one of the challenges. But expansion to all the veterans would likely increase in the need of upwards of 10,000 dentists to be hired within the VA system, and adding an additional 16,000 dental treatment rooms. So we're talking about a huge expansion. And right now, if you look at where we have resourced our dental clinics adequately, we can provide care to match the private sector at that 65% utilization rate. And we also meet that, I can go back to that geospatial information systems, about 76% of our veterans live within a 1 hour drive time to our VA clinic. So we resource those appropriately as best we can. Addressing those rural needs will be challenging. And that's where we have the opportunity to partner with other programs such as community health centers and federally qualified health centers.
Well, thank you, Dr. Trapp, Dr. Weaver, and Mr. Leviton. We appreciate all of the time that you gave today and in preparation for the panel. And thanks, everyone, for tuning in. I will turn it over to Annalise for the next steps.
Wonderful. Thank you so much, Dr. Boynes, and thank you to all of our panelists. I know there was a lot of activity in the chat, and so I hope that we'll continue those conversations as we move into the coffee break. But before we do that, I would like to introduce Lindsey Church, who is the co-founder and executive director of Minority Veterans of America. And they're here to share a little bit about their organization as one of our highlight philanthropies today. Lindsey.
Hi there. Excuse my dog is jumping into the camera because, that's what happens in a pandemic. So good morning, everyone. Thank you so much for having me. I'm Lindsey Church, Executive Director and Co-founder of Minority Veterans of America. I just want to start with a thank you to Annalise and the AIDPH team for including us in this program and highlighting the work that we do. I'm likely preaching to the choir, and after listening to you all for the last 30 minutes, as I say this, I'd be remiss if I didn't discuss the importance of accessible, affordable, and equitable dental health services. I grew up in a military family, the child of a woman veteran who was the child of a Korean War veteran. My family served for love of country, but they also did so to escape deep generational poverty. As a kid growing up, dental health was viewed as a luxury. I remember at one point telling my mom it was time to go to the dentist after years of ignoring the dental problems and pain I was experiencing, only to find out that I needed thousands of dollars worth of care that we just couldn't afford. Our options at the time were to pay the rent and provide food, or pay for extensive dental treatment that seemed frivolous compared to our other needs. Flash forward to 2012, I myself leaving the military with DD 214 in hand, ready to head home to Seattle, Washington. I knew I was technically eligible for care in the community for a duration of time, but let me tell you, dental was the least of my worries when returning home, medically retired with complex and severe injuries that took priority. I did finally end up getting seen at a predatory dental clinic that was being offered as an option by VA at the time, only to receive countless bills for their services that by law were never supposed to be sent to me in the first place. My story of transition isn't unique. After service, many veterans struggle to access dental care across the country and often end up receiving minimal treatments, such as tooth extractions, due to the overall cost of preventive care. For minority veterans, this problem is exacerbated by structural, economic, and cultural barriers to access. On average, veterans of color earn 13% lower wages than white veterans and are 55% more likely to live in poverty. Women veterans earn 14% less than male veterans and are 47% more likely to live in poverty. Trans veterans are twice as likely to be unemployed, and LGBTQ people overall are 71% more likely to live in poverty than their cisgender and heterosexual counterparts. This paints a grim picture for those who need employment, livable wages, and health insurance outside of the VA to be able to access care. In addition to socioeconomic inequities, there are additional barriers to access, such as medical racism, micro and macroaggressions by providers, and a baseline lack of culturally and trauma-informed care. This is particularly prevalent in the lives of racial and ethnic minority veterans. Studies continue to show that Black, Indigenous, Native Hawaiian, and Pacific Islander and Latinx veterans experience disparate outcomes in dental and medical care that contribute to higher overall mortality rates in these communities. So where do we go from here? We must take a two-pronged approach. First, creating programs and services that are designed to address some of the inequities I spoke of, prioritizing veteran communities most in need. Second, we must adjust our policy strategy to prioritize equity and access for those who have been historically marginalized and disenfranchised. These two strategies have the ability to meet current needs and help to stabilize the community while we address the long-term systemic needs. This is what Minority Veterans of America is all about. Our organization works to create community belonging and advance equity for the minority veteran community. Our programmatic work seeks to meet our community where they are and deliver programs to serve their current and future needs. At the same time, we prioritize designing and advocating for policies that will address many of the equity gaps we see today. Our work prioritizes the needs of veterans of color, women, LGBTQ, and religious and non-religious minority veterans. You can learn more about our work, our organization, and our policy priorities at minorityvets.org. I'm going to drop all of these links, so don't worry. If you're interested in supporting our work and getting involved, there are lots of ways to do that, including becoming a member of the organization. You can find info on the website, joining our volunteer leadership team at bit.ly/MVA volunteer, or by giving to support our mission at givebutter.com/MVA 2021. If this is the only time our paths cross, I just want to end with a bit of gratitude for all the work y'all do to support the veteran community. Dental health is something that's often, or that folks often think of last when it comes to veterans' overall health, and that view has repercussions in the health outcomes of our community. So thank you for your work, and thank you for having me here today.
And thank you, Lindsey. I could not have even dreamed of a better way to end this session today than highlighting the disparities and also thanking you for the work that you're doing for the veteran community. It's very personal for all of us, and that passion shows through. And if you're interested in learning more about Minority Veterans of America, you can do that again during the coffee break. We have a special lounge, and so you can certainly talk with Lindsey and learn more about MVA there. So just a few housekeeping things as we move into our coffee break. The CEU code, and I'm going to pause to make sure everybody has a place to write this down. The CEU code is CARE 216 VET. So CARE 216 VET. And you will use that code to claim your continuing education credits at the end of the conference. We'll send out an email today for you to evaluate and claim your CEUs. We are also encouraging everybody as we move into the coffee break to please visit the virtual booths and lounges for our partners, philanthropy, and poster presenters. The booths have information, static information and resources, and then the lounges are the place to really have conversations and engage. And so we encourage you to visit both, but lounges are where we'll have the interaction. And I'm going to briefly share my screen so that folks know exactly what I'm talking about when I say the lounges. And so this is what it looks like in the Hubelo app. You will navigate to the lounge, you will select a seat, and then you can join with both video and audio. I also want to say a special thanks to our partners at CareQuest Institute, the American Dental Association, Patterson Dental, Aspen Dental, and Delta Dental Foundation, because they have supported this work for quite some time in our event today, and we'd love for you to learn more about them in the lounge area as well. So please come back in about 30 minutes after your coffee break, and we'll enter into concurrent session.